Long Beach Chapter Women's History Month, Women's Health Issues and Care in the Face of Politics. The Long Beach Chapter just celebrated our 92nd birthday and has been a respected and active member of the Long Beach political community. This league serves the voting public by having events like the one today to provide nonpartisan information through speakers and discussions in order to educate everyone that has the right and power to vote. Before I introduce three distinguished women on the panel, I'd like to talk about the National League of Women Voters' work related to health care. The League takes positions in public policy after extensive research and investigation. The League's healthcare position, under the heading of Meeting Basic Human Needs, enumerates services the members believe are of the highest priority for the basic level of quality care, including the prevention of disease, health promotion and education, primary care, including prenatal and reproductive health care, acute care, long-term care, and mental health care. This position also calls for a national health insurance plan financed through general taxes, commonly known as the single-payer approach. Since 2010, the League of Women Voters has worked tirelessly to ensure access to affordable, quality health care for all Americans and celebrated the passing of the Affordable Care Act. The League continued to fight attempts to repeal the ACA and to limit provisions that provide health and reproductive services for women. The state leagues worked on their legislatures to implement ACA, and the League signed on to an amicus brief in the challenge to the ACA, which was upheld by the Supreme Court. In 2013, as opposition to the ACA was raised in the legislative, regulatory, and judicial processes, the League of Women Voters submitted comments opposing religious exemptions for contraceptive services. This debate continued in the courts, and the League joined with other concerned organizations in opposing broad religious exemptions to the requirement that all insurance plans provide access to contraception as basic care in the 2014 Supreme Court case of Burwell versus Hobby Lobby stores. As the opposition intensifies, the League will continue their efforts. We are very lucky to have three distinguished women on our panel that have been very active in promoting equality in the treatment of women's health and reproductive rights through the education, judicial, and medical fields. I'd like to introduce each panelist one by one and allow them time to elaborate on their work in women's health care. And if you didn't see, in the back we have index cards with some pencils, and we'd like you to write down any questions you have and then funnel them through Jordan and Jane, and we will have ask those questions from you guys during a session at the end of, towards the end of this period. Jennifer Russo, MD, MPH, and is the medical director of Planned Parenthood for Orange and San Bernardino counties, where she oversees the clinical care of 100,000 patients seen for over 200,000 visits per year. Planned Parenthood of Orange and San Bernardino counties has 9 health centers throughout Orange and San Bernardino counties. Recently, this organization has developed and opened a primary care practice for women in their reproductive years called Melody Women's Health. This organization has also served as a California clinical lead in an app called PP Direct that provides birth control pills and urinary tract infection treatment. Dr. Russo has been instrumental in the clinic oversight of these programs. As an assistant professor in the Department of Obstetrics and Gynecology at UC Irvine, Dr. Russo teaches residents and medical students and mentors research projects. Dr. Russo attended college at Cornell University, where she graduated with honors in biology and society in 1994. She attended medical school at George Washington University. As a medical student, she served in the National Health Service Corps. She completed residency at Harbor UCLA Medical Center in Torrance, California, and then worked as a generalist OBGYN for a federally qualified health center for 5 years in San Diego. Returning to training, Dr. Russo moved to Pittsburgh, Pennsylvania for a fellowship in family planning and completed a master's degree in public health in 2012. Dr. Russo has conducted research on medical guideline compliance among primary care physicians, harassment of abortion providers, and long-acting reversible contraceptive use. She has served on the American College of Obstetrics and Gynecology Committee for Underserved Women, the National Medical Committee of the Planned Parenthood Federation of America, and the Southern California Credentialing Committee of Planned Parenthood. She was recently voted Physician of Excellence by the Orange County Medical Association. Please welcome Dr. Jennifer Russo. And I'm going to say this, can you, yeah. Jennifer's going to tell us in her own words about all the work that she's done. Thank you.
Well, you covered a lot. So just to give you a little bit of an overview, can you hear me okay? Is the mic? Okay. Planned Parenthood of Orange and San Bernardino counties has 9 health centers, 6 in Orange County and 3 in San Bernardino counties. And we have, as Lisa was saying, recently started a practice called Melody Women's Health that also offers primary care at 6 of our health centers. And the philosophy around developing that practice was that we felt that we could really take more care of our patients. Many women were coming to us for family planning services like preventive screenings, pap smears, breast exams, contraception, and abortion, and that we could expand our focus and really be able to take care of young women for their asthma or high blood pressure or diabetes. And we've had 10,000 women either be assigned to us or choose us as their patients, and have a new campaign to really encourage our existing patients to stay with us and make us their primary care provider. So we feel very good about that service, and really we see patients who are able to, whereas in the community a lot of times women seeking primary care, as you may have experienced yourselves, have a lot of their reproductive health needs dismissed in favor of prioritizing other issues. But we really try to prioritize those needs, so make sure that a woman who has medical problems is on birth control, so that she can plan her pregnancy and have her medical condition optimized before she gets pregnant, things like that. Also, we recently started an app called PP Direct, which offers UTI treatment and birth control pills online through an app. So a woman would go into the app, enter information in response to a questionnaire, and then a clinician reviews that information and prescribes her treatment. And right now, our affiliate is overseeing that application for all of California. And the goal is to expand it to all states in the coming year or so. So we're also really excited about that. We really pride ourselves in being innovative. And I'm happy to answer questions about our services, and especially in the context of the greater political environment, what we're experiencing now as we go through and answer questions.
Thank you. Thank you so much. The next distinguished woman on our panel is Dean Judith Dar. Judith Dar is a clinical professor at the University of California, Irvine School of Medicine, and will be a visiting professor at UCLA School of Law in the spring 2018. She is the former interim dean and professor of law at Whittier Law School in Costa Mesa, California. In November 2014, Professor Dar was appointed chair of the Ethics Committee of the American Society for Reproductive Medicine, where she has served as a member since 2008. Thank you. Since 2002, Professor Dar has been a member of Medical Ethics Committee at UCI Medical Center. She was elected president of the American Society of Law, Medicine, and Ethics from 2009 to 2011, where she also sat in the board of directors from 2006 to 2012. She also serves as a co-chair of the ABA section on real property, trust and estate law, bioethics committee. In 2012, Professor Dar was elected to the American Law Institute. Professor Dar has spoken extensively on legal, medical, and ethical issues in reproductive medicine, including giving testimony to the National Academies of Science and the California Legislature. Her law school teachings include courses in property, wills, and trusts, bioethics, and reproductive technologies in the law. In 2006, Dean Dar published the first and to date only casebook in the field of assisted reproductive technologies called Reproductive Technologies and the Law. A second edition of the book was published in 2013. Her latest book, The New Eugenics, Selective Breeding in an Era of Reproductive Technologies, was published in early 2017 by Yale University Press. Her scholarly work includes over 100 book chapters, articles, white papers, and editorials on a range of topics, including prenatal, genetic testing, human reproductive cloning, regulation of reproductive technologies, and malfeasance in the provision of assisted conception services. She is the recipient of 3 outstanding teaching awards, including the J. Healy Distinguished Health Law Teacher of the Year awarded in 2015. In October 2013, she was awarded the Suidel J. Washer, MD, Distinguished Service Award by the American Society for Reproductive Medicine. Professor Dar is taught as a visiting professor at UCLA School of Law, UCI School of Law, Loyola Law School, and the University of Houston Law Center. Yes, a big mouthful, but thank you for joining us, Judith Dar.
Thank you so much for including me in this wonderful opportunity. Just to see the facility is a privilege, as well as to see so many friendly faces and collaborators in the concerns that we all share. So I'm going to take my 10 minutes. Is that, I think
Yes,
that's the program.
please.
Just to speak with you about the work that I do and the issues that I care about and how it can be helpful to you and to our communities. So as Lisa mentioned, my main focus is on family formation. So I have become interested in, and have been interested in this area really since law school, and trying to navigate the intersection between law, medicine, and ethics as it relates to reproduction, and particularly family formation. So what I study are the tens of thousands, actually in the United States, millions of individuals who want to have a family through natural means, but are unable to do so for reasons related to infertility. So the epidemiology teaches us that about 10 million Americans experience infertility, and it's divided equally between men and women. Often women are the ones who are associated with being infertile in pair, but in fact male infertility occurs at exactly the same rate. And what I study are two aspects of infertility, that is the ways in which people are prevented from forming their families. I study medical infertility and social infertility, so let me speak briefly about those. Medical infertility is a little bit easier to grasp. It's of course the ways in which a person's reproductive or sometimes endocrine systems can fail them in their efforts to conceive the so-called, the old-fashioned way, as we say in the field. Or I call it dinner and a movie. So natural conception, which can be effective for many people, has its barriers through infertility, structural and otherwise. And there are marvelous technologies that can address infertility. The one I'm going to speak about today is in vitro fertilization, in which the gametes, the eggs and the sperm, are removed from the body. They're introduced in a so-called test tube baby. It's not really a test tube, but that's the word that's often used. And an embryo is hopefully formed and transferred back to the woman's uterus or to a gestational carrier in order for a child to be born. And the technology, as marvelous as it is also quite expensive. So there are many barriers to accessing this technology throughout the world, and I'm going to speak about throughout our country. So that's the medical side of infertility. Social infertility affects people because of the social structure in which they live. So they aren't able to take advantage of these methods, the natural methods, so to speak, because they're an unpartnered individual or they're in a same-sex relationship. And natural conception in those populations just would never yield a pregnancy and live birth. And those individuals can be benefited also by reproductive technologies, by IVF and sometimes other technologies. But again, there are a number of barriers to their accessing these technologies. And the book that I just published takes a look at some of the more obvious barriers to accessing these technologies, as well as what I try to explore in the book are some less well-known, but I think really vital ways in which there is suppression of women and men's reproductive desires. So the most obvious barrier to accessing these technologies is cost. IVF costs on average $15,000 in the United States, and for the most part it is not covered by insurance. There's a battle, and as part of my role at the American Society for Reproductive Medicine, I'm part of a number of lobbying efforts to improve and increase access to insurance coverage for these technologies. But to be honest, it's been a rather frustrating and really unyielding effort over the last 10 or so years. At least 85% of all fertility care is paid by cash. So for many people, a $15,000 cash payment is just not accessible. Moreover, IVF is successful about 1/3 of the time. So if you just kind of play with the economics of that, that would require someone to go through 3 cycles in order to be successful, and then the mounting costs are quite apparent. So we participate in efforts to increase, as they say, increase insurance. And the one tiny area that we've had a little bit of success in is fertility preservation for women who undergo cancer treatment. Gonadotropin therapy will typically yield a woman infertile after cancer treatment. So there are many protocols in which she can take advantage of preserving her fertility prior to undergoing treatment. And even that is not covered. In California, we had a bill last year that we were hopeful would pass and be signed by Governor Brown, but alas, it didn't make it through. So that's a small but important advocacy area for us in order to increase access. Generally, to try to increase access again, there's just not that much receptivity at this point to requiring insurance companies to cover this. And what's happened is there's been a gap that's been filled to some extent by private industry, and particularly with leaders in the tech industry, who make as part of an attractive benefits package access to reproductive technologies, either through egg freezing or even surrogacy and IVF. So we're hopeful that maybe some of those partnerships will spur other industries to join in, and then we can perhaps confront the public funding sectors with a little bit more robustness. All right, so that's the cost issue. There's also barriers to accessing these technologies based on race and ethnicity. And no surprise to probably this group that in this country, there are wide disparities in both access to health care and health outcomes based on a person's race or ethnicity. The study done by the Institute of Medicine a number of years ago reveals this in very persuasive ways. And infertility, the problem I think is even magnified for the following reasons. Just studies show that women of color are more likely to experience infertility for a variety of reasons, and when they do get treatment, they're less likely to be successful. So they don't respond as well. They have higher rates of miscarriage, early term labor, and so on. So that factor alone, and then if you combine it with other features, accessing these technologies through the ordinary channels creates a real stratification in the field. It's very concerning and impacts communities in very significant ways. Another barrier is marital status and sexual orientation. Surveys of physicians in the field indicate that even today there are physicians who refuse to provide service to individuals based either on their marital status, typically because they're unmarried, or their sexual orientation. Either they're in a same-sex relationship or they describe themselves as being part of the LGBT community. And as it turns out, maybe shockingly to some, this is perfectly lawful. As you might know, at the federal level, there's very little protection for individuals from discrimination in the healthcare arena based on their marital status or sexual orientation. So that a physician can just say, I'm not going to treat you because you are, and then fill in that demographic feature. At the state level, there's a little bit more protection. As you know, we have this system in which the states can provide more coverage in the civil rights arena than we do at the federal level. And about half of our states do have protection against marital status discrimination in the healthcare field, and about a third or so based on sexual orientation. But that's clearly not enough. And it continues to be the case that patients who have no other avenue toward family formation in which perhaps they want to be a biological parent can access those technologies. And it's very concerning. And I know as an ASRM, it concerns me when I hear about our members who refuse service, and they stake out an individual professional conscience objection, saying that providing service to this patient who has this so-called lifestyle, that's a word I hear a lot, because the person's religious objection dictates refusal. That concerns me a lot, although as a lawyer there's not a lot in some cases that I can do about that, and so that's another barrier. And then finally I'll just mention disability. For many, particularly women who experience either mobility, sensory, or cognitive disabilities, again, there's a real pushback from physicians to provide care. And the surveys indicate that physicians feel that they can exercise discretion over the parenting ability of prospective parents by saying you're not in a position to be a mother, you're not in a position to render good child rearing services, and therefore I'm not going to put myself in the position of facilitating that for you. So that's just a discretionary barrier. Also, there are more structural barriers for women who are disabled, but the one in which there's an exercise of discretion because of some judgment based on their prospective parenting capabilities really concerns me. I think we all know that none of us are terribly good at predicting the future, and doctors, no offense, Dr. Russo, are not any better, are not any better at predicting that. In fact, the general literature on women who either are disabled at the time they reproduce or become disabled later on reveals that they're just as good and bad as we all are in parenting our children. And there's no reason empirically for denial of services on that basis. So again, that is of concern to me. So part of the advocacy in my book is to come up with some creative solutions for the ways in which we can enhance access and suppress some of the discriminatory practices that I have observed in my work in the field. And I'd be delighted at the Q&A to speak with you about that. So thank you so much for the opportunity.
Thank you. Our last speaker that we're going to have today is Michele Goodwin. Professor Goodwin holds the Chancellor's Professorship at the University of California, Irvine, with appointments at the School of Law, School of Public Health, Department of Gender and Sexuality Studies, and Department of Criminology, Law, and Society. She is the founder and director of the Center for Biotechnology and Global Health Policy. It is an internationally praised reproductive justice initiative. She is an elected member of the American Law Institute and American Bar Foundation Fellow. Just got back from doing a speaking engagement in Israel, so we appreciate you being here today. She researches and writes about legal concerns with regard to the human body. She is an acclaimed bioethicist and prolific author. Professor Goodwin has published with Forbes, Salon.com, and the LA Times, Chicago Sun-Times, Houston Chronicle, Christian Science Monitor, and the New York Times, among others. She is the author of several highly acclaimed books, including the much-anticipated Policing the Womb, which chronicles how women's reproduction has become the political scapegoat in Congress and legislatures across the U.S., resulting in the rise of personhood measures, practices that force women to undergo cesarean births under threat of court order, practices that force abuse of prosecutorial discretion that results in the criminalization and punishment of pregnant women for falling down steps, refusing bed rest, or attempting suicide, and policies that dramatically erode reproductive liberty. She was also a part of a documentary called Birthright, a War Story, and Professor Goodwin frequently lectures worldwide on issues involving constitutional law, human rights, reproductive justice, bioethics, and health law. She served as a visiting professor at the University of Chicago and as a visiting scholar at the University of California, Berkeley, and Columbia University Law School. We are very honored to have Professor Michele Goodwin on our panel today.
Thank you so much for that incredibly generous introduction. I'm honored to be with my co-panelists who are good friends of mine that I've known for a very long time. In fact, I've known Dean Dar since I began law teaching, so we go way back, many wonderful dinners and whatnot over the years. And also, I'm really thrilled to be here and part of this audience. Thank you so much for having me. Thank you very much for being here on a Saturday morning. So let me begin my remarks by placing this all in historical context. That is, we're gathered here this morning to think about women's health in a political time, in a political context. And I think it bears noting that in 1966, Dr. King received Planned Parenthood's first Margaret Sanger Award. It's an annual award that was to recognize champions of women's health, champions of women's reproductive rights. Most people are not aware of this, but in 1966 he received this award, and the speech that he wrote in receiving the award is really quite profound, and I think bears remembering for all of us and bears our acknowledgement of it, because in that speech Dr. King said that it was urgent and that it was necessary that women be able to control their own reproductive health care. He said that family planning was urgent and necessary. And in fact, he said that if a group of aliens visited the United States, they would say that the U.S. is governed by a nation of insane men. Now, his words, not mine, but I think it was placed in context that it was obvious how women would suffer without being able to have control of their own reproductive destinies. For this reason, he said that it was logical that the civil rights movement would have a common bond with the women's rights movement, He said that it was not possible that a woman who was familiar with an agrarian economy and came from an agrarian economy where having 10 children would be the norm could possibly be able to endure and thrive in an economy in an urban center living in a tenement, that it was just not possible. In fact, his words, that it was actually cruel for a child to come into a family where it was not wanted. That was 1966. But it wasn't simply Dr. King who had this vision and message that connected human dignity, civil rights, women's rights. It's in 1969 that George Bush I said that we need to take the sensationalism out of family planning. He was the person who pushed Title X legislation in Congress. Title X legislation is that which provides reproductive health care services for the poorest of Americans. And when you hear about today the need to defund certain organizations, what is it about? It's about Title X. Take away that Title X funding. But who's hurt by that? It's the poorest women. And so I think it's worth placing in context that when Title X legislation was not only enacted by Congress, it was signed into law by Richard Nixon. Now place that into context today, where there is a bill that is being floated, the Make America Secure and Prosperous Act of 2018, seeks to remove $300 million in Title X funding. I think it's important to realize our history in this manner. I think it's also important to realize, too, that in evoking George Bush I, that we also remember his father, Prescott Bush, because Prescott Bush was actually the treasurer for Planned Parenthood.
Wow.
Exactly. And I say that because one really critical point amongst the many that were brought up by my colleague and friend, Judith Dar, is the real urgency for engaging in empirical analysis, in understanding what we're actually talking about. I think it's really, it's far easier to pull the wool over people's eyes when people don't have information, right? Completely apart from our panel. I think about the value of an education. And a value of an education in the United States might mean that there would be people who would think long and hard before they want to go into coal mines and make that their future. And education helps you to understand that black lung disease is the result of being trapped miles under the earth, chipping away at little pieces of black coal, and that there is a different and robust future that people could have. I think about that within the context of reproductive health care as well, because in fact we're living in parallel universes, different universes, where one might think, for example, that to terminate a pregnancy, that it would be the most illogical thing that a woman should ever want to do. I mean, if you took a survey of people, they might think, given the rhetoric of what we hear today, a couple of things. They might think that contraceptives are abortifacients. They're not. That would be the message that they would get from Burwell v. Hobby Lobby, where a company says, well, look, when I think about these three contraceptives, I think of them as abortifacients, and I don't support abortion. But what medical science would help us to know that's clear and empirical is that contraception is not abortifacients, right? You can't use a contraceptive to terminate a pregnancy. You cannot, right? It's just simply not possible, right? A pregnancy doesn't occur until an embryo has embedded into the uterus. That is what a pregnancy is. A contraception will not work on that. It won't. But in fact, if that is the messaging that you hear, then that's what people would believe. But there's also something else that's deeply disturbing about this moment as well, is because an abortion is actually 14 times safer than carrying a pregnancy to term. Now, we may not like that, and I'm a mom, and I love my daughter, I love my stepson, I really, really do. But the reality is that a woman is 14 times more likely to die during childbirth and delivery in the United States. That's real. But you would not know that given the political rhetoric of our time. And why does this matter? Because there are any number of reasons that a woman or a girl may seek to terminate a pregnancy. Sometimes it is to save their lives. Sometimes it is because of cases of rape and incest. And if anything that we know in an era of Me Too is that that is a reality in our society. As much as we still struggle to come to terms with these realities, they are real. And I think it also bears mentioning then what the hostility right now in terms of women's reproductive health care results in. The United States now leads all developed countries in maternal mortality and infant mortality. According to Central Intelligence Agency data, and here we're not talking about some obscure left-wing source, and governmental data, that we rank 50th, 51st in the world. It's safer for a woman to give birth in Bosnia than in the United States. Texas is now considered the deadliest place in the developed world for a woman to give birth. Texas. Now, when you understand that Texas has been one of the states with the most robust targeted regulations of abortion providers that have sought to shut down the clinics that provide the range of services for women, then perhaps that's not a surprise. Because after all, when a woman is pregnant, she needs help. But if the clinics are closed, then she can't get that help. This is particularly acute and dangerous for women who live in rural areas and who are the poorest amongst us. For African American women in the United States, the rate of death during maternity is nearly four times that of white women. It is sad and it is tragic. But I will also say that there are spaces of hope, because in a state like California, and we still have our struggles, but California is the safest place now in the United States for a woman to give birth. And you'd have to think about the gap between policy making in California and that in Texas. And you think about the progressive work being done by organizations, being led by my colleague here, Dr. Jennifer Russo, and that speaks very differently, when we're talking about empowering women. So I just want to spend a moment to just touch on a couple of additional issues that I think are important for us to think about and how these issues hit home. Shortly after President Trump assumed office, he signed the Mexico City policy, otherwise known as the Global Gag Rule. Now, what the Global Gag Rule does is almost as it says, which is that it prohibits organizations that receive funding, human rights funding, USAID funding, from being able to do any type of research related to abortion services, from being able to provide any kind of communication with regard to abortion services, from being able to perform abortion services of any of those NGOs. So it's a gag rule. If a person comes in and says, I've just been raped, and I believe that I'm pregnant, then those organizations can't mention anything about abortion so long as they have received US funding. There have been European governments that have said, well, we will step in and we will provide funding, and then you don't have to worry about the US funding. Well, the United States has made it clear that even if you receive funding from other countries, you're still barred and banned from mentioning this. Now, I think about this in the context of the following, and there are stories that you've heard about involving 10-year-old girls, 11-year-old girls in various countries in Central America, Latin America, that have been raped and are pregnant, very often by some member of the family. And then you hear this rhetoric, but she's going to be happy to just have that baby. And you have to unpack what that means. How much of that is influenced by the politics of economy? Because this is the messaging that we have sent from the United States, that this is how we think about these issues. And I think that that's really important for us to give consideration to. I'm also concerned about the space of morality legislation and regulation that's taking place. So no longer just simply religious objections to women having access to contraception, right? But now companies can have moral objections, right, to women being able to have access to contraception. I'm concerned about the plethora of targeted regulations of abortion providers, these trap laws that have been passed in the United States. And it's important to note that in 1973, when Roe v. Wade was decided by the U.S. Supreme Court, that was a 7-2 decision. This was not a close call, right? Not at all. In 1973, the Supreme Court, in I think in many ways a beautifully written opinion, recognized how women had been stereotyped over years, stigmatized, how this had set them back in terms of their education, how this had set them back economically. The Supreme Court recognized that not only was unplanned for, unwanted childbirth a setback for women, it could be a setback for the children, right? And they also mentioned that that itself could cause both physical and also psychological harm to women. I think it's a beautiful opinion for that, but it's worth noting that between 2010 and 2013, there was more anti-contraception, anti-abortion legislation that was proposed and enacted in the United States than in the 30 years prior combined. Right, so to think about 1973, 7-2 opinion, and between 2010 and 2013, just what we experience in our country. And I want to close with just the following thoughts in terms of what that represents. We've heard a lot recently about the importance of intersectionality. And really, you know, the theory about what it means to be intersectional dates back a very long time. And I want to share a name with you, Dr. Paula Murray, who is absolutely a wonderful phenom of her time. And I won't say more until Q&A in case you ask me about this. But I think that it's very important that we understand, in fact, what this intersectionality means. And that is, during that same period of time, 2010 through 2013, we also saw robust gerrymandering taking place throughout the United States, and voter suppression, and the suppression of Black people's vote in the United States. We have to connect these issues together, that which was happening against women was also being met with that which was happening against populations in our country that had struggled for civil rights. And I think placing these in context helps us to understand also those with whom we need to be in collaboration with when we think about our role. And I think it's particularly pertinent this morning, given where we are with the League of Women Voters, to understand what voting rights mean, not only for women and women of color, but also for all Americans and for people of color generally in the United States. And with that, I'm going to close. Thank you.
Thank you. And that's why me wanting to have this be a full room, this is such an important topic, both even more so for younger women than it is for those of us that are outside of childbearing years, but this is just a very important topic. So all three of you really touched on kind of what's going on in our current administration right now and the challenges that women are facing with health issues. The current administration has been promoting the support of changes to diminish the coverage of female contraceptives by insurance companies, push the stripping of government funds for women's public health care facilities, and even cutting millions of dollars in international health care funding for those most vulnerable. As we start to open up this discussion, what do each of you see as the greatest threat that women in the U.S. really face over the next several years, and will we be able to really recover from that? Is my opening question to you guys.
So I would echo Professor Goodwin and Dar's comments about some of these threats, and just say that my feeling is that there is a desire to return women to the 1950s. That's what Make America Great Again means. And so I don't think that we should fool ourselves that there's not an understanding of what the impact is of the various threats that we are facing, that it is clear that's the goal. And I think when we see that we have a president who is clearly hostile towards women, and is yet aligned with an evangelical community, and we see that support doesn't seem to be flagging, I think that we understand that it's not about any particular ethos, it's the core is that there's a fear that women having control over their reproduction presents some kind of threat. And that is my viewpoint on it. But I think in terms of those threats, we discussed the global gag rule. There's a threat now that that gag rule will essentially be applied to Title X. And so just for a little background on Title X, Title X provides 4.1 million women with access to preventive services. So that's 800,000 PAPs a year, and 5.8 million STI tests. So centers, it's a federal grant that regions can apply for and then distribute to local organizations like Planned Parenthood, but many other primary care and family planning organizations. And it's a block grant that has certain criteria for applying, and that those were recently changed to increase scores for organizations that solely educate on natural family planning and abstinence. And so that gives priority to organizations that have that agenda. Nothing that is wrong with natural family planning or abstinence. We support it as well, but that shouldn't be prioritized because those methods are actually not very effective. So that's one big threat that I see. And then also, women are threatened by the removals of ACA advances. So Obamacare really provided access to women for no-cost preventive services, no-cost birth control, and that's being eroded. The individual mandate has been repealed. Bare bones plans are now existing again that just provide for like catastrophic care but don't provide comprehensive care. All of the pre-existing condition exclusions are being removed. And so gradually, they couldn't completely overturn it. So I think it's very important for us as voters to be aware of how they're picking away at it. And amidst all of the sensationalist news, there are actually very dangerous policy changes that are occurring that are flying under the radar. Religious exemptions are extremely concerning, and then obviously the Supreme Court, which I'm sure my colleagues can speak on a lot more in depth, but we know that if we have another option for a justice to be appointed to the Supreme Court, we threaten Roe v. Wade. And we also know from international precedent and the precedent in this country before Roe v. Wade that where abortion is illegal, women die. Women will still have abortions. That is clear from all of the evidence. And so when you make illegal something that 1/3 of all women access in their lifetime, you increase the risk that they'll access it unsafely. And so it's just critically important that we pay attention to these, some of the bigger and smaller issues that are occurring that affect women's health care.
Did you want to comment on the
Sure,
constitutional aspect?
Sure, I would echo that, including what we know internationally, so that even when the global gag rule has been in effect, it's not that internationally that has suppressed women terminating their pregnancies. No, they continue to do so, only under unsafe, illegal means. And here I want to share with you two other points of information as well. And that is, the World Health Organization has consistently said that an abortion, a legal abortion, is as safe as a penicillin shot. Now, I share that with you because I believe that empirical information is very important. We can do with it what it is that we choose, but I think it's important that we know that. But when little girls who've grown up in war zones, and we know that in war zones there are incredibly high incidences of rape, when those girls then have found their way to clinics and organizations that have received this USAID funding, and they are not informed of their options, it's not as if they don't know that they don't want that pregnancy. They will just simply go to someplace else where it means that their lives are placed at risk. For us, we are so many decades removed from that time in which medical wards, maternity wards were full of women who were dying, who came in because they had just had a back alley abortion. And unlike so many millions who just simply died in alleyways, in their tubs, on their dining room tables, These were women who survived. In the book, Leslie Reagan's book about abortion, which I think is really phenomenal, she tracks what it meant in Chicago and New York, where overwhelmingly the women who were in for medical treatments during the 1960s and early 70s were women who were trying to survive from botched illegal abortions. That was the backdrop of Roe v. Wade. Now, at a time in which abortion has been legalized in the United States, we don't see that anymore. We don't see it, so we're so far removed from what that reality looked like. But that was the reality right here in the United States. And we don't revisit what those pictures look like of 14-year-olds and 15-year-olds or women in their 20s and 30s who already had 3 or 4 or 5 kids and just couldn't stand to have another one because they knew that economically it would not be viable for their families. I think these are the realities that we have to sensitize ourselves to. But let me just say, in terms of what the future happens to represent, I'm deeply concerned about the health of women and girls in the United States. And that is because when we think about the high rates of maternal death, the high rates of infant mortality, these are increases. It's important to note that the United States signed on to an international agreement where it, along with other countries of the world, would try to improve maternal health and safety. In a report that was released last year, the United States was the only country who had signed on to the agreement where the maternal mortality rates skyrocketed. They went up. Every place else, they tapered or went down. Ours went up. And I think it has a lot to do with this era that we're in. And if I could, for just one moment more, say that it's a satellite of issues, right? It's not just abortion at all. It is sex education, where that has now become taboo, right? It was in the 1970s, part of home economics, people need to know about their bodies, how does your body work, this is what a pregnancy is. Now, we can't talk about that's taboo. Children are not supposed to know about that, right? Abstinence only, which we know does not work. If you look at the work of Naomi Kahn, and it's interesting, Naomi and June, red states, blue states. It happens to be that in red states there are the highest rates of unintended unwed pregnancies, highest rates of divorce, highest rates of teen pregnancy. And these happen to be in the states where we suppress sex education. It does not work. What then is the future for a 13 or 14-year-old girl who's pregnant and who at 14 or 15 is giving birth? What kind of economic future will she have? What kind of economic future will the boy who's 15 or 16 have? What type of life will she have at 21 with 4 children? These are realities that we don't talk about, but that we should. But I'm also deeply concerned about the criminalization in this space. I'm deeply concerned about prosecutors saying that they want to go after women who've taken an illicit drug during their pregnancy. Now, I don't think that women should be taking illicit drugs during their pregnancy, but I also am sensitive enough to know that people struggle in their lives. And I'm sensitive enough to know that addiction is a disease, and that no woman wants to just simply harm her baby, but certainly prison is not the answer. But this also we have seen in Alabama in just the last few years, there have been over 500 women arrested for taking some form of an illicit drug during their pregnancy. Now you may want to know what that means. In Alabama, there are women who were serving 20-year sentences, even with their babies being born healthy, because they took a plea deal, because a prosecutor has come after them and said, you know what, we got our hands on your medical data. And if we take this to trial, that jury is going to think of you as a bad mom. So here's the deal. 20 years, or we'll do something more dramatic. Or in the cases of women who want to have a natural birth and are being threatened by their physicians with arrest if they refuse to have a C-section. You can't make this up. Yes, but this is true. This is happening in the United States, and you can see it detailed in the Birthright documentary that you mentioned. So these are the types of conditions that I'm concerned about that are taking place across the United States, that are impacting the lives of poor women. And I'll close with this. I believe that poor Latinas and Black women were the canaries in the coal mine in the 1980s in this regard, in 1990s, but they no longer are. These are the types of issues that are now haunting white women, poor white women, and even now middle-class white women throughout the United States, and I'd be happy to talk more about that. And it's deeply concerning to me.
Thank you for that. I mean, we all understand and know, and I think a lot of the women in this room, what is at stake and what is happening right now. And thank you for your comments. We all know also that California is forward-thinking, and really, it's like you said, it's safer to have a child in California than any other state in this country. From a perspective of being the medical director of Planned Parenthood in San Bernardino and Orange County, what funding changes from a federal level, and I say it from a federal level because California, we're a little forward-thinking, but from a federal level recently that has really affected your ability to provide any kind of treatments to women in our Southern California region?
Well, I agree that we are fortunate to be in California, and I want to kind of address the question of defunding Planned Parenthood because I think there's a lot of misconceptions about what that means. We don't have significant direct federal funding. We are a healthcare service provider, so we bill for the services that we provide. And many of our patients are on Medicaid. About 70% of our patients in California are at or below the federal poverty line. So defunding really means saying Planned Parenthood can't accept Medicaid. And so far, the federal government hasn't been successful at achieving that, but none of us are kidding ourselves that that's not going to be an effort that continues. It definitely will. And I would say that's why your work is so important to get people galvanized to vote, to try to change things and put in some safeguards. So I think defunding is a significant threat. In California, we're really fortunate to have a family planning program that is subsidized by both the state and federal government. States have an option of creating these programs and getting a subsidy from the federal government, but not all states do create them. But in California, we have a program called FPACT. It's Family Planning Access. I always forget the name, something in treatment, and care treatment, I believe. And that program covers family planning care for patients, so contraception, preventive screening, PAPS, STI testing. And there have been a number of studies on that program that's shown its effectiveness. So for every dollar spent on family planning, there's $9.25 of savings on additional health care. So pregnancy care, but a number of other, pregnancy complicates health care for women. It can complicate their health in general. So, and then also as Dr. Goodwin talked about, the risks of pregnancy are significant. And so complications related to pregnancy are very costly. Even if we're just looking at a very kind of bottom line approach to public health, we see the importance of it. And so far we've been fortunate in maintaining that program, but I do think that there are going to be also federal attacks on these waiver programs for family planning care. FPACT has also been shown to have decreased the abortion rate in California by 1/2, decreased the unintended pregnancy rate by 82%, the teen birth rate by 71%. So we know that these programs are effective, and targeting them and targeting contraception is counter to the supposed belief in being against abortion, because all of these programs help to prevent abortion. So even if we're along those lines, we should recognize that there's a lot of hypocrisy there. And then Title X that we've discussed already, it being threatened, is another concern. But we're very fortunate to live in this state, and we should continue to support our elected officials in this state. And not to get too partisan, but I would just say in Orange County there are some significant races, and there's an opportunity to potentially create better advocates for women in our county, for those of you who are from Orange County.
Thank you. So we've put together some questions, and one of them, and you guys have touched a little bit on it, is what are the arguments that make religious beliefs or conscience an exemption to allowing equal access in women's health care. I know we had a conversation about a wonderful article about conscience. So we'd like to talk to that.
Yeah, so I was going to answer the previous question about
Oh,
the
I'm
greatest.
sorry.
Oh, no worries. It'll fold right in. So it's perfect.
Perfect.
Just to speak at a bit of a metaphysical level about that, I worry that we will fail to seize the moment that our voices are now raised a modicum in order to make the significant advances that we deserve and that we can. So I think we are at a moment politically and in other avenues that we need to seize our power. And wherever we're gaining that power from, it doesn't have to reside in that particular arena, and we can use it to expand the voice that we have collectively. Now, I'm not suggesting that women are a voting bloc and that we're always going to vote in the same way or have the same perspectives, but I think we need to confront some of the myths that we're beginning to unpack in other arenas. So just to transition then over to this idea of assertions of religious and conscientious freedom, let me talk about that both sort of generally and then what's happening in the Supreme Court. So in my field, in reproductive technologies, I know that's a real segment and niche and so on, but we see this quite often where physicians will assert a religious objection or a conscientious objection to providing service to a person based on the physician's background. And as I was telling you, in some cases that's perfectly lawful. California, again, as Dr. Russo mentioned, is a special place in that regard. There's a well-known case in the field. At this point now, about 10 years ago, a lesbian couple went to a San Diego fertility clinic and sought care. Turned out that the patient had a condition, PCOS, that made it such that she actually needed IVF in order to reproduce. She went to her first visit, and the physician said to her, well, if you do need any kind of aggressive care, if you will, advanced care, I can't provide it because my religion prevents me from providing care to you because of your situation. And it's unclear whether she was referring to her lesbian status or her not being married. This was before marriage equality, so she was not able to be married. And the woman and her partner pursued a claim against the clinic, which was ultimately heard by the California Supreme Court. And in a unanimous decision, which is unusual in any court, the court said that physicians cannot deny medical care to women or to anyone actually in the state on the basis of their assertion of religious freedom, which is preempted by the California civil rights laws, which at that time protected against discrimination on the basis of both marital status and sexual orientation. So that is the only case of its kind in which the court has sided with the patient, but there are still many threats to health based on these assertions across the country. So just finally, speaking about the Supreme Court decision, we'll see the end of June. As always, will be active and be interesting. The Masterpiece Cake case, which is now testing out the Colorado Civil Rights Act, very similar to some extent as, and maybe I'm sure that Professor Goodwin can speak more about this, to the California law. The question is going to be whether the court accepts this assertion of expression, artistic expression, protected under the First Amendment as opposed to a religious assertion. So it's morphing where these refusals and this discrimination has been couched in religious freedom, and it's had quite a bit of success, Hobby Lobby and so on. Now there's this broader-based agenda to bring in other opportunities to channel these kinds of conducts, and I'm very concerned about that, because a baker's expression of artistic freedom, you know, maybe we view that as legitimate or illegitimate, but you know that that is just the basement, if you will, for building assertions in every area. And again, I've talked to physicians who feel that they are creative, if you will, in the way that they approach care, and what would prevent a physician who has the permission of the Supreme Court from saying, I don't want to apply my creative skills to you because I have an objection, a conscientious objection. And then just one more thing. In terms of just going back to the beginning about capturing this moment, what I don't hear enough of is the idea that brave women like the ones that are flanking me have a conscientious objection to not providing care and advocacy for women. What about that? Why is it a negative assertion that I have the right to not involve myself in health care or advocacy for women? I think that the affirmative right to assert a conscientious objection to not providing those services is equally vital, and that we need to grab onto that and promote it in a much more robust way.
And I'd like to add to that, which is that we see not only physicians now asserting this, but pharmacists as well. I know, and this is why I think it's always important to go back and understand what's happening at the ground level, because for so many in our society, and I count myself amongst those, I mean, who have a privilege, right? We have the privilege so that we have the ways in which we're able to pay our ways into comfortable situations, right? You know, you can pick up and choose. Whereas for many women who may live in rural areas, who may be very poor, you can't just pick up and choose. But dignity is at stake. And what comes to mind for me is a playbook. And the very playbook that we're hearing now that is to discriminate against women, to discriminate against LGBTQ persons, to discriminate against trans persons, was used at a time to discriminate against black people in the United States. People are shocked now to know that African Americans were denied services at hospitals that were predominantly white, that there were African Americans who literally died on the steps of hospitals, and that very often religion was used, right? That black people came from a tainted race of people, that God had cursed African Americans, and that they just couldn't help, you know, because they were just not supposed to serve these cursed people. These were the justifications that were also used to uphold anti-miscegenation laws, which were upheld in our country until 1967, when the Supreme Court struck those laws down. And so we see that playbook being used again in many different contexts. And so the point that I wanted to make about pharmacists also engaging in this, what does this mean when a person just simply wants her birth control pills to be refilled? And the pharmacist says, no, I have a moral objection to birth control pills. Go someplace else. Well, if you live in a rural community where this is the only place for another 50 miles, then what are you supposed to do? Or what about in the case of rape and you need Plan B? And the pharmacist says, well, no, I don't support Plan B, which is not an abortifacient, right? It is a contraception that will prevent, right, the pregnancy from taking place. And there have even been cases of married couples, and this I find very shocking, that I've reported on in a recent article, with married couples going together, saying that, look, we can't afford to have more children and something happened during our natural reproduction, or after the movie and dinner. And pharmacists still saying, well, we don't care that you're married and that you had that lovely dinner and movie. We're still opposed, right? And so I think that it's important that we pay attention to these issues, and then that we vote according to our passion and our consciousness.
And, you know, I mean, I think I would also add on to everything that you're saying, just from the perspective of a provider, that to me, it's, I'd like it if we could start to frame things as conscientious provision, because actually I feel it's quite easy to use your power as a physician to refuse services. And, you know, yesterday I was in clinic and I had a patient who was really struggling with her decision about whether she wanted to have an abortion. And so I always sit down with those patients and say, we have no agenda. Our only agenda is for you to make the decision that's right for you. And so tell me a little bit more about what's going on. And she said, well, you know, I feel like I'm in a position where I could potentially have this child, but I don't feel ready. My partner and I just broke up. I don't feel prepared to be a single mother right now. But I called my primary care doctor, and he told me that it would be wrong for me to have an abortion and dangerous. and I have some questions about where my baby is in the stages of development right now, because he told me that it would feel pain. And so all of that was very damaging to her. Physicians have a lot of power, as we all know, in our relationships with our patients. And so I just kind of want to, I feel for me that I've made a decision to be an abortion provider at some cost to myself, and I also find it extremely rewarding, but I feel like that's a conscientious choice. It's not something that happens by default. Nobody default becomes an abortion provider. And the other thing I would say is just that there's this conscientious objection stuff has been going on for a long time, and I think it's one good thing about this being in the news. There are a lot of bad things about what's happening right now, but I think it's bringing to the forefront that this is happening a lot. And I see it amongst my patients frequently. There are studies. There was a study about 10 to 15 years ago where a resident actually called all of the Los Angeles pharmacies and asked if she could get Plan B, and was told by a significant proportion, something like, and I may be quoting the numbers wrong, but it was significant, like 20 to 30% of pharmacies did not stock emergency contraceptives because of this conscientious, and they're businesses, so they have some options there to make those decisions. So just my provider fine point on that issue.
There was, just to kind of close this up also, there was a recent article written by Lisa Harris, Dr. Lisa Harris, and she talked about how conscious and religious freedom at the scope of women's health care is not a black and white issue, even though politically they're trying to make it a black and white issue, either you're for or against. It's very complex. And that, I'm going to read one quote, research shows that complexity is an antidote to social conflict. Oversimplification of issues leads to vilification of those with whom we disagree. So it is not black and white. It needs to be looked at from a either individual case basis or a holistic view, and putting it in a black and white term is actually a disservice to all the women.
And can I just say, this is in part why I began with Dr. King, right? Because in this climate, one would not know that many of the early proponents of women's reproductive health care and family planning were members of clergy. Were members of clergy who had congregants die and suffer and felt compassion for their congregants. And we would not even know that. Even some of the early cases in this domain were clergy writing amicus briefs or support. And so I think it's important that we return to that when we think about what compassion means, compassion is also about care for women, care for women's health, care for women's dignity, care for women to be able to have vibrant lives.
So I'm going to kind of take things a little bit differently, but there was a question we had from Jane actually on our committee. What would having an ERA specifically written for women do for women's health? And I think that might be an interesting topic, being that we're talking about trying to make legislative changes, right? Who would like to comment first?
Do you want to comment first, Ms. Reedy?
Yeah, I'm trying to think. I think of a morass developing in which it would be litigated in terms of its interpretation and so on. Yeah, I think a statement, a global statement, which is embedded in the, I assume you're talking about a constitutional amendment, would give verdure to the notion that the women's issues are on par and so on. I'm just not sure how it would play itself out. I hate to be so pessimistic about it. I think it would be more of a statement and an important one, but legally, the way it would play itself out, I'm not convinced that it would make improvements, and perhaps I'm missing some important elevations. Because, and again, if you don't mind, I want to go back to something that we were discussing. The idea that the Department of Health and Human Services now has an Office of Religious and Conscientious Freedom it should be of concern to all of us for a couple of reasons. I mean, we're in an era where the way in which things are presented have a lot of impact. And the idea that the federal government would institute this kind of an office has a lot of impact for its symbolism and the status that it has been accorded. So that's one part of it. But building on that, it's very, and this is what Dr. Harris's piece talks about. It's a wonderful piece in the New England Journal. I highly recommend you take a look at it. But it not just is a status, but it assumes only really one perspective, and that's what her piece is about. It assumes that a person's objection, a conscience will lead them to object to the provision of services or to the dismissal of requests and so on. So that's why I'm not sure, blending these two items at the federal level, I'm just not sure how practically they're going to impact us in positive ways, which is just to say we need to keep working at the grassroots level the way we have, because that's where the changes are going to occur.
And I'd like to think about it from, take an approach to this that's slightly different, and that is to think aspirationally about what would it mean in a society where women were treated with dignity when they sought care, whether it's dental care, it's reproductive health care, it's anything, right, where their voices actually mattered. Some of you may have read about Serena Williams' account after giving birth. And this is why I say that it's not just abortion, it's also women who want to carry pregnancies to term, who are dying in the United States, who are not being heard. Their voices are not like they're not articulating, but in Serena Williams' account, I really commend that reading to you. Some of you may know that she has had her own health struggles, right? And so she's acutely aware. She's a world-class athlete. Many people consider her one of the world's leading athletes. She knows her body. But even after giving birth, where she was tracking her own health and told her medical providers, look, I believe that there's a problem and here is why. And they said, just go back and just go lay down. And she said, no, I need to tell you, because I've had a history of blood clots and ... here are the tests that you need to take. No, just go to, and in fact, when she did it, she didn't want to scare her mom. Her mom was in the room, so she left out of the room to go tell the providers because she didn't want her mom to get nervous. And she had to insist, you will do this now. And it turned out she was right. She could have died had the intervention that she was demanding not have carried through. Now, for so many women, for them, it's very difficult to make those kinds of demands. They feel vulnerable to their medical providers. I've recently participated in a congressional briefing on maternal mortality that I coordinated, and I got a phone call from an attorney, Judge Glenda Hatchett, who's now in private practice, a retired judge. And she called me in Italy a couple years ago, and it was about the Philando Castile case. She was the family's lead attorney on the civil litigation. But what I had not known, and she came back to tell me, was that just a couple months before that, her daughter-in-law died 10 hours after child delivery in Los Angeles. Her daughter-in-law, multilingual, pilot's license, phenomenal woman. I mean, just an amazing woman. But again, a case in which, and she's African American, had been saying, and her husband, there's something wrong. Look at the level of blood. Look at the level of blood that's in the IV bag and that's coming out of the catheter. Look at it, look at it, look at it. Look at it, look at it, look at it. When finally, after 10 hours, doctors decided to actually pay attention to her, 3 liters of blood in her abdomen. Preventable. So what does an ERA mean? I think in part what you're speaking to, what does it mean in a space in which women's voices matter? What does it mean when we think about this as in pro your health? What makes you healthier? What makes you better? What makes you thrive, right? And not just for women, but also for girls too.
So we have some great questions from the audience, and although I have several that I didn't even get to, one of them that we still have, and I do want to talk to that, is as we grow older, women who are fighting for women's equal treatment for healthcare becomes more about saving young girls that face future effect by government decisions. So we have some questions that came from our high school intern, Jordan Webb, and I'm going to pick one of those so that we can talk about it. So let's see.
She had a really good question about confidentiality and minors. That
Yeah,
I-
in addition, so I'll pick that one.
I
Thank you.
might answer that one.
In addition to, so that's my question, Jordan's question, in addition to reproductive rights and sex ed, education can be extended to minors learning their legal rights to health care. What rights do minors have when it comes to reproductive health care?
So,
Thank you.
sorry, I'm controlling from the panel. I just think it's really important, though, that as a physician, that young people understand what rights they have, and that we're very fortunate in California, again, that we have very good laws that basically allow minors to, over the age of 12, to consent for sexually transmitted infection testing and prevention without parental consent. At any age, a minor can consent for pregnancy care, birth control, sexual assault treatment. And there was something really important that I wanted to mention, because I think it actually applies to every woman, that you may be familiar if you have private health insurance with an explanation of benefits form that you get after every doctor's visit. You're like, why are they sending me this? I know I went to the doctor. But the intent is to prevent fraud. And so that you're aware, I received this, so that, yes, that was me, nobody else is using my insurance or my personal information, so that part's good, except that it presents a safety issue. And so women who come for abortions, I see many, about 85% or so of women who have an abortion have insurance, but they don't use it. A small proportion use it because of a fear about confidentiality, and either because they don't want their partner to know that they're having an abortion, or just in general, I don't want some healthcare company to know that I had an abortion, which says something in and of itself, given that a third of women are having abortions. But for young people, I think it's really important that teens be aware that they have the right to request that that explanation of benefits not come to their house. So if they're on their parents' insurance, and fortunately the Affordable Care Act allowed people to stay on their parents' insurance until they were 26, they can request a confidential communications request that's available online and exclude themselves from receiving those explanation of benefits. And I think it's important that we spread the word about that, because it's a very important health protection for women. And that's my 2 cents on that.
Can I ask you a follow-up question?
Yeah.
No, what you said is so important, that the laws have become much better at permitting girls as minors to consent to their own health care in a variety of ways, substance abuse and STI testing, yes, and so on. But what about the abortion exceptionalism? And most states do require, again, I would love to hear your experience, some parental involvement, and then there are judicial bypass options.
Mm-hmm.
What's your experience with that aspect of it?
It's a really good question. I think the question has an agenda, which is a good agenda. I think, well, first of all, again, in California, every state has different laws regarding parental involvement in healthcare. So in California, if a woman is pregnant, she is emancipated and can make her own decisions, but that's not true in every state. So that's an important distinction as well. I've also practiced in Pennsylvania, where that wasn't exactly the case. So, and in Pennsylvania, there are parental notification and consent laws. So that has circulated through public referenda in California. You may remember that this has been on the ballot many times. And I think to a lot of very good parents, they think, of course I would want to know if my daughter was having an abortion. I want to be involved in that decision and then help her make that decision. But there are many young people who don't feel safe going to their parents, or maybe they've got great parents and they just don't want to tell. Or their parent could be the cause of the pregnancy. So what it involves in Pennsylvania, for example, is if a young woman under the age of 18 wants an abortion without notifying her parents, she has to go through a judicial bypass process where she seeks, it's usually family court, that a judge actually makes the decision for her. And in Pittsburgh, there's a place that they go, there's a whole process, but it takes a few more days. And in addition, in Pennsylvania, there's a 24-hour consent law that says that providers must consent a woman for abortion more than 24 hours before she has the abortion, which also delays her care. And some states have 72 hours. Some states have now gotten creative and said it has to be the same doctor who does the consent, and it has to be in person. And so like states like South Dakota, where there's one provider who flies in, that provider now has to come in a week in advance and stay there until he or she can do the abortion for the patient. So, these are just barriers, and they put children at risk. And it creates a situation where we see a lot of young people attempting to obtain medication to cause abortion. I see patients who, I've seen patients who've put things in their vagina, ranging from a variety of different objects,
Have
or
the boyfriend use a baseball bat.
get hit, fall, throw themselves down the stairs. And we're seeing that happen a lot in Texas now, that the numbers of women who are doing things like that are increasing. So.
And I'd like to add to that, if I may, and that is to add both in the space of thinking about immigration issues here and domestic violence. And that is to say, when we think about youth and the concerns that youth have, I find it quite the struggle that is with as much attention, and it's appropriate attention, we need to do more with regard to domestic violence, that the incidences of domestic violence amongst young people it's there. I mean, it's higher than what it should be at all. And I hear this from deans of students at universities across the country. I've heard this from students who are concerned about their classmates. And so I think also when we think about education, that piece is important. It's become very difficult for immigrant women worried about ICE to report, right? If you possibly go and report to police that you're the victim of family violence, domestic violence, there's a concern that you might be deported and separated from children. And that, I think, is a grave concern. And I want to add just one more historical layer to this too, which is that, it's not an isolated matter, or it's not just that it just happened, that we find ourselves having this conversation about the status of women. I think it's important to put that in context, and maybe that's something more that gives us to fight. And here's what I mean. Marital rape was legal in the United States just until a couple decades ago, right? I mean, and we're talking about cases that have involved husbands drugging their wives, the wives unconscious, videotaping the rape. We're talking about cases where husbands have planned the kidnapping of the ex-wife, but the divorce hasn't gone through, and she is kidnapped with his friends, and then he rapes her and doesn't deny the rape, but the judge is saying, well, look, sorry, you have to follow the law, and in this state, there is no such thing as marital rape. Your husband can't rape you. Right? It's important to put in context that as a new country starting off, that we could have decided that we would be a society that would be equal, equal rights for women, right? But we didn't, right? The rule of thumb comes from, right, the narrative of you can beat your wife so long as the instrument that you use is no thicker than your thumb, right? So where we find ourselves today, sort of thinking about how how we think about a future, we have to understand what that past has been along so many different axes. And I'll just conclude with saying that, part of what I find important to introduce to my scholarship is this history to help us understand these issues, including the Supreme Court over time making judgments about the value of women's lives, right? I mean, this comes from our Supreme Court saying that, well, women with their delicacy, you'd think that they were talking about donuts with the way in which the court has referenced women, but with all of their delicacy and their gentleness, their place is meant to be in the home, and that they are not prepared for the more robust aspects of life, such as becoming an attorney, etc.
Can I say one other thing? Good point. I think though that was like a little smoke and mirrors, because they were really afraid of what would happen if the women did do those things. But just one other issue about young people, because you reminded me, Professor Goodwin, when you brought up the incidence of intimate partner violence among teens, and something I just wanted to add on to that is that 25% of young people report that they've had some kind of reproductive coercion. And so I think when we think about intimate partner violence, we really think about violence as physical violence or sexual violence, but there's also a significant problem of reproductive coercion, and that goes back to the need for confidentiality, because many women report that their partner is either trying to sabotage their birth control, force birth control, force them to get pregnant, force them into sex without it being a physical act like a violence. And this is a huge problem, and we see many women, many patients who say, I can't be on birth control pills because my partner is watching, or my mother is watching to make sure I get a period every month, so I can't use a birth control method that's going to keep me from getting my period. And it's a problem that I feel like it would be great if young people start to discuss amongst each other, or continue to discuss, to bring it out of the shadows, because I think with light it will hopefully resolve, but it's becoming a big issue.
And I think part of that might be that sex education is not being done in schools these days, and so without that education and that knowledge, they kind of are running a bit blind. I wanted to ask more about that, but we actually are running out of time. So along the lines of really the Me Too movement, really giving women a voice, several of the questions that came from the audience was about what do we do next? How do we help? How do we get involved? I mean, we have obviously an audience of women that are on the League of Women Voters and some other folks here, but a lot of the questions that we received from the audience was about what's the next step for us to be able to take that voice and do something with it.
Well, I think that it's really important, if we have privilege, that we raise the voices of people without it. And going back to the discussions about immigration and ICE, there are many women who are very afraid to report that they're in a situation where they're being harassed or abused, because if they do, they put themselves and their family at risk. And so, this obviously is a problem that occurs to all, it occurs to all women. It's happened to me, it's happened to every other professional woman I know, but if we think about that, and that it could happen to me in the operating room as a medical student, that what's happening to a woman who is, working as a farm worker, or what's happening to a woman who is a housekeeper in a hotel, that's a place that there's so much opportunity, and we know that where there's that opportunity, there are people who are going to prey on those women. So if we can elevate those voices as much as possible, it's critically important.
Again, as I said earlier, I think it's a moment that we really need to seize upon. And Professor Goodwin mentioned the spate of legislation in TRAP laws, the targeted regulation of abortion providers, and the Guttmacher Institute tracks those very assiduously. And there's about 200 or so bills that get introduced annually. They reached a peak, I think, in 2013. But nevertheless, this is a place where advocacy at the state level can be quite effective. And I have to say, it shocks and, to be honest, disappoints me when I see women legislators, and there are certainly many, who vote in favor of these laws. And again, I confess I have a certain perspective, and I feel like it's voting against self-interest, not just for themselves and their daughters and so on, but for generations of women to come. So to the extent that we can become involved in many of those, and again, we don't really confront them in our state, but there's no reason why we can't stand out and use our voice and use our power at this point to elevate the conversation, to be unafraid. I feel in some ways that we've been afraid to take on these topics because they have such emotional symbolism that people are so quick to shut down the conversation, and we really can't permit that to happen and have to talk past that in ways that are to our benefit ultimately.
And I would echo that, particularly highlighting a culture of silencing women. And silencing women when women have power. So then it's also important for women to do just as what you say, which is to claim the power and authority that they have, right? And to realize the value of their experience, the value of their status and stature, to make the appropriate interventions. And so I think about that because I've had my own experiences of standing up for others. I've had the experiences of having experienced and wondering, oh my goodness, what do I do with what just simply happened to me? And I also want to say too that I do think that due process is important in these spaces as well, because there's also been a legacy in history, particularly involving African American males in the United States, with torture and abuse on allegations that were unfounded with regard to sexual assault. But I see this as a moment that can be more of a movement than simply a moment, and there's far more to uncover. One of the things that I think about is not then just what happens in schools, but what's also our responsibility as aunts, uncles, parents, grandparents in terms of providing the young people in our lives with a language for understanding. And I'll just share a story. When my daughter was 3 years old, it dawned on me that I should have a talk with her about how babies are born, and have a talk with her about relationships and people. Because it dawned on me that for children who are victims of sexual assault and abuse, they didn't know how to talk about it. There was no language to describe what happened to them. And I think that there are ways. It means that we have to be nimble in figuring out. For me, it was saying there's a magic wand, and there's a special egg in the magic wand, trace of magic rays. And my daughter went on to educate adults around her. Do you know about the magic wand? I got a call from her godparents. They had taken her on a trip, and he said, the entire way we had to hear about this magic wand. But part of it was also a conversation about showing her how strong her parents were, and that her parents would always be there to support her, and no one could ever do any harm to her parents, because one of the narratives that's used in abuse is that no one will believe you, and we will hurt the people that you tell. And if you're a child and you've heard that, but no one has ever told you, we're strong, nobody can hurt us, you can tell us anything, then you don't know. Right? So it wasn't just about magic wand and spray, but it was also about the strength of parents, and also about how relationships happen, right? First you have to be friends, and then friends may hug, and just in a way that for this 3-year-old wasn't corrupting, but was empowering, so that she could recognize things and then be able to have conversations. And I have to say, it's certainly possible that I don't hear everything from my daughter at all, but I can say that now, having a 23-year-old boy, the conversations that I've had that I didn't think that I would be, having, because she calls me and because we talk.
So, going along the lines of kind of changes and keeping the voice heard, a lot of women are now running for office, public, local, state, office. And I think part of what we should do, and I'll just add to that, is really looking at what each of these women believe in, how they vote, how they intend to go forward with their legislation and their efforts, and voting for the women that are coming up with that. I mean, having to be educating yourself on what it is that they are going to put forward, and make sure it's part of what agenda you want to be able to further this effort. So I think that's something we need to really think about. What are the questions? Let's see. I'm going to give you one of the statements that someone said here. Although someone cannot support abortion due to religious beliefs, they absolutely support contraception. So she's male or female, is listening to you, and they said that although my position is difficult, there are others like her. And that's to the point that you said, Dean Dar, that contraceptives should be looked at in a completely separate light than abortion. And so this person is actually looking at, help us kind of understand that, and that should be part of the education, is really separating that and understanding that contraception really avoids abortion, and so that's something that we need to make sure we do not erode in this country, and that's really important.
Absolutely.
Although I would add to that and just say I agree 100%, but there are women who use contraception and it fails. Contraception is not 100% effective, so we have to also be sensitive to those women and their efforts to avoid pregnancy, and have them able to access, not be forced to continue a pregnancy because they had a failure of their contraception.
you.
And going back to education. One of the questions was, given K through 12 education policy as set at local level and given emphasis of abstinence as the best form of birth control in some localities, do you think we need a federal policy guiding sex education in K through 12, especially in light of your comments about intersectionality?
Well, I know, well, first, let me go back to say this, the importance of voting, because in many of the states, and we've done a study at the Center for Biotechnology and Global Health Policy, to find where are the states in which there are the highest rates of maternal mortality, infant mortality. It turns out that those are the same states where there is the emphasis on abstinence only and whatnot. But also what we wanted to see is, okay, where are women in terms of their political representation in that state? And it turns out in the states that have those high peaks, right, those are states where women make up only 4% of the legislature, 5% of the legislature. Now they make up at least 50% of the state, but they're woefully underrepresented at the legislative level. So one of the ways in which I like to think about this is that it's not just federal legislating. Really, these are at-home issues. And I believe that with greater representation and greater use of women's voices at the local level, right, that we would see these changes taking place. Now, I will also say that at the federal level, it has been a redeeming force for African Americans, right? When you think back about Alabama and the hoses and dogs being placed on African Americans who just simply wanted the right to be able to attend schools with books that were whole, with buildings that were not falling down. The state of Alabama was resistant. A lot of southern states were, and it wasn't until there was federal legislating or Supreme Court cases that then there was some liberation and movement in those directions. So it's not to say that the federal government hasn't been a force for equality, civil rights, and justice. It has, but I would love to see these issues just simply at home where we could resolve these issues. And if that means more women running for office and using their votes effectively, then so be it, and please do it.
I'd like to say a word about language. And I've always felt that language shapes perception, and thus it's very important to use the right language. And we're very familiar with how language shapes perception in our world, the world we're talking about today. For example, the terms pro-life, pro-abortion, pro-choice, and anti-choice. Now, I think everybody has their own preference in that range. I've just suggested 4, but there are others. And whichever of those words you use to describe the position that you think they're affiliated with is going to shape the perception. Someone who is pro-abortion, it may be perceived as demanding that anybody who has an unintended or unwanted pregnancy have an abortion, and that's certainly not what that is about. So we could talk, although the time is running, about taking hold of and taking power over language. But just to your point about sex education, I mean, just for example, it's always struck me that the word abstinence is not the right language to use for a 15 or 16-year-old person who is experiencing changes in their body that they don't want to abstain from what their body is essentially hormonally driving them to do. So what about a better word like deferral or wait and see? I mean, because to impose the message that you have to abstain, it sounds rather permanent and persistent. And I don't think that's right. That's not what the message is. And so that's why I just urge us to really think carefully and to calibrate the language to the message that we're really intending to serve.
And I want to mention too that, you know, we're really fortunate in California, again, that we have the California Healthy Youth Act, which now mandates comprehensive sex education in public schools, and there's a bill on the table to add charter schools to the mix, which should get interesting. And, you know, this is really pioneering. I'm not sure how many other states have these laws on the books, but the schools are very much now trying to come into compliance with the act, educate their teachers. We're in the process of developing curricula to help the schools. We have a strong health education program at Planned Parenthood. And I think it's a very hopeful sign. So I think there's a lot of depressing news, but I would just go back to our advocacy is working, and we can set an example in this state for the rest of the country.
And I got just a teeny bit to that, which is to say, if we look at countries that we would say perhaps are pure countries, so we might think of France, Germany, England, Switzerland as pure countries. If you want to see what they do, they have dramatically lower rates of sexually transmitted disease amongst youth, dramatically lower teen pregnancy. I mean, across all of the indices that we would say we would want to aspire to, theirs are flat towards the bottom. What are the differences? One, sex education starting K through 12, like as in K, as in first grade, right? Finding language to talk with children about their bodies. It doesn't have to be mysterious. We've made it mysterious, when in fact it doesn't have to be. And it's interesting because we're a society that pushes certain images at them, right? In their superhero movies and whatnot, the women are deeply sexualized, their breasts are popping out of the, costumes and whatnot. And so we give these images to children, but then we say, but we don't want you to see it and know it. But we want to take you to the movies, right? And Disney does this too, right? I mean, it's all over the place, right? But then we say, we put a gag order, basically, on children and youth. So I think that even if we look at what happens elsewhere and say, where do we want to fit? Do we want to be a nation that achieves along these lines? Well, maybe there's something that we can learn from our peer countries that actually do this a bit differently. And boy, what would that mean for our children's health, particularly given that we know that certain sexually transmitted diseases during their youth may later lead to cancers or infertility.
Yeah. So I want to thank all three of you for coming today. My name is Lisa Andrea, which I didn't even say in the beginning. I am an active member of the League of Women Voters here in Long Beach, and we want to make sure that every meeting that we have, we are sharing information that makes everyone much more informed of a voter, and that everyone should get out and vote and be informed of the candidates that you're voting for, and to use your voice, especially our woman's voice right now that is elevated right now. We are a nonprofit, so please, we appreciate anybody who wants to join as a member or wants to donate to our League of Women Voters. And we do have the president, Kim Ritter, he'd like to say a couple words.
Yeah, again, thank you so much for coming today. It was so articulate and thoughtful and just an amazing presentation, so thank you. And I also want to recognize the hard work and effort that went into producing today's event. So I want to thank Lisa and Jane and Jordan, our high school intern, for organizing everything today. It was just phenomenal. So thank you so much. And then finally, for our members